It's like a diamond ring, it's a precious thing. And we never want to lose it. It's like a favorite song that we love to sing. Every time we hear the music, and we're in this love together. We got the kind that lasts forever.
Good morning. Good morning. This is Karen Dodson from the All of Us Research Program at the Medical College of Wisconsin. And I just want to welcome you this morning. And we're going to be at the table, always having serious conversation. And today we're going to be talking about breast cancer. And as you know, breast cancer affects women as well as men. And so we're going to really have some guests. They're going to talk about it. We're going to be able to allow for you to call in if you have your questions. I want you to make sure you grab a pencil and a pen and get ready to call in when you have questions. And the number is 414-444-5253, 414-444-5250. So we're going to enjoy today as far as learning good, solid information. And of course, I have my special doctor with me today, Dr. Kevin Izzard. Good morning, Dr. Kevin.
Good morning, Karen.
How are you? How are you?
For those who can't see, Karen is on the road today.
I'm on the road, but I'm still here. Hey, technology is great, right? So I just want you all to know that Dr. Kevin Izzard and I, we have really been having conversation about what type of topics we want to bring to you all. And so today we're going to bring breast cancer because actually this is Breast Cancer Month. So now you're going to see a lot going on this month related to breast cancer. And Dr. Kevin Izzard, we are ready to start diving into this conversation this morning, correct?
I think so.
So breast cancer, and Dr. Kevin Izzard, there's a lot that goes on with it. There's a lot as far as related to the different types of genes that people might have. The All of Us Research Program, they actually test for some of those genes. And so we'll be talking more about that. And things that we can do to help prevent the cancer from getting to the levels that we can't do anything about, or the treatments don't respond as well. So Dr. Izzard, can you just kind of tell people like what and when do people know that they might have breast cancer?
Well, this is an area that's very interesting as far as it comes to precision medicine. It just by coincidence this past week, I had dealing with a patient right now who has had breast cancer for a while and had decided to go kind of a more alternative route. And so she's been getting some follow-up PET scans. And unfortunately, we found this week that her cancer's gotten worse. Breast cancer.
When you say alternative treatment, so are you saying that this person chose not to have the amputation?
Yes. So she decided to go with kind of an immune stimulator kind of route. So she was working with this clinic in California. And so they were, giving her things to try to promote her immune system with the hope that her immune system would kick in and kill the cancer. But unfortunately, that's not been the case, with her. So you got to be careful, when with these things. And it's already a tough situation when you hear the C word. Everybody, gets understandably, panics when you hear, oh, you have cancer. And for a lot of people, they don't know where to go next. They don't want to lose a body part. In this case, women don't want to have a mastectomy. But on the other hand, you got other women that like Christina Applegate and like Angelina Jolie who decide that, look, it ain't worth it. Just, take my breasts, like, and they can, and Christina Applegate's had, actually both of them have had a, very productive career even after that. So it's not the end of the world.
And Dr. Israel, why did they choose to go ahead and take that aggressive approach?
Yeah. Now I think Christina Applegate actually had cancer, but Angelina Jolie has the BRCA gene, which puts her at increased risk for breast cancer and for cervical cancer. So she just said, that's one of the treatments you can do. One of the options is to rather than having to do these follow-up mammograms every year and worry that it's cancer, if you remove the breasts, well, then you can't get breast cancer. So it's a choice that people make, and it's something that you have to have a real conversation, with your doctor, with your oncologist, with your family, because there are consequences of doing that. But for some people, just the peace of mind is worth it. Now, another interesting thing in this realm is that, well, you talked about how do you know you have breast cancer. So mammograms have actually been changing as far as the frequency. It used to be every year. Now we say, every couple of years, if you're low risk is okay. The problem though is that people remember back when Fox 6 had like a breast buddy kind of thing where, every month they would say, get a friend and, and remind them to do a breast exam, self-breast exam. And the idea is that you're looking for lumps, which would be kind of obvious, looking for, anything that's hard in your breast. You might be also looking for indentations that you might see in your breast. You're looking for a rash maybe on your breast that wasn't there and doesn't go away. You're looking for discharge. You get nipple discharge, especially if it's bloody nipple discharge. All those things are red flags that suggest that something is not right and you should have it investigated. Now there's an organization called the U.S. Preventive Services Task Force, and they make recommendations about screening tests. So things like mammograms and pap smears and colonoscopies and prostate cancer screening and all those things. So they were, up until a few years ago, they were recommending that, that women do self-breast exams. Well, what they found was that as we started doing this and pushing it, that a lot of women were finding lumps in their exam. And so they go to a doctor, and of course the doctor would have to follow through, and they would get an ultrasound or a mammogram. Well, mammogram maybe followed by an ultrasound. And so a lot of them were being sent to surgeons, breast surgeons, to get those lumps removed. And the vast majority of them were benign, meaning that they were not cancerous. So you get all these women excited about this lump that it's probably nothing. So some women just have, lumpy breasts. And so they actually changed the recommendation because they couldn't find evidence that us promoting self-breast exams was reducing the number of cancers. It was just causing more benign lumpectomies. So that's kind of where things are, which makes it very difficult for someone like me who's a primary care doctor to explain to women that, well, you should do breast, you should really be aware of your breasts, but we don't want you doing the self-breast exams, because in my career, almost every woman with very few exceptions who's had cancer has come in. They told me, I feel a lump. We send up an ultrasound, they find, or if we send up for a mammogram and they find something. So definitely women are the first line on this. They need to know if your breast feels different, there's something there that, that shouldn't be there. So they're, women are much more likely to find this than I am on a routine exam. But doing the self-breast exams, when we at least push it, it results in more benign findings. So one other area where we need more research, and that's why we need people to be involved in things like All of Us, where they can get into these research projects, these research studies where they're looking at breast cancer incidence and who is, especially with us. And we'll get to this here talking about Black women and breast cancer, because Black women are more likely to have a more aggressive form of cancer and earlier.
That's really something that when I was reading, it talked about African American women, Black women, as far as with cancer. And when I started looking to see like what's really going on with the All of Us research program,
Mm-hmm.
and actually they mentioned that there are over 38,000 participants that share a family history of breast cancer.
Mm-hmm.
And then when I started looking a little bit more, they have around 10,000 participants that actually contributed data related to them having breast cancer. And so that really shows that this is really kind of allowing for over 135 studies to start, for researchers and doctors to dive into the researchers' workbench. That's what they call it for people that are wondering what I'm talking about. They can go in and pull out information. And so uh, right now we have over 135 studies going on as it relates to breast cancer. But Dr.
Mm-hmm.
Kevin Izzard, you said
Mm-hmm.
something that really kind of resonated with me and also with the community, that African American Black women are more affected and they have a more aggressive
Mm-hmm.
type of cancer.
Yeah.
Why is that?
That is the $100,000 question. Um, there are a lot of theories. Actually, I was looking at an article just last night. It was from a researcher from the medical college, who was looking at people who are regular listeners to the show. We call when we talked about prostate cancer. I brought up this a heat map. So it's a map looking at Milwaukee, southeastern Wisconsin. So looking at Milwaukee County, Waukesha County, Racine, Washington County. So it looked at I showed a map and it showed the areas where there were prostate cancers, and and then a follow-up map looking at where the deaths were, and disproportionately the men who died from prostate cancer were in basically Milwaukee and Racine, Kenosha area. And so the question was, why is that? And that was a big question we have. There's a similar map for breast cancer, and you see that, and this was this was from the Journal of National Cancer Institutes, and it's called Historical Redlining and Breast Cancer Treatment and Survival Among Older Women in the United States. So this isn't just looking at Wisconsin, this article, but there's another one with, and this is Kristen M. Beyer, who was a researcher at the medical college. And
Yes, Christian. Yes, I know Christian.
you know,
Yes.
Kristen, yeah. There's another one looking at in the Milwaukee area, or the southeastern Wisconsin, and it shows that the vast number of breast cancer deaths are in Milwaukee, and they broke it down by race. And needless to say, the hot areas are the areas where you have more African Americans. Now, the question is this race that's causing this, or is it something else that's associated with these areas? Like, for instance, is living in a higher density population, does that cause breast cancer? Is there something that people have been exposed to, like more pollutants or things that are in cities like Milwaukee, as opposed to rural areas, that might be causing breast cancer? So maybe there's other things going on, that maybe it was the cell phone towers. Who knows? So what she looked at in this study was looking at redlining, and so areas where there tends to be redlining, where historically, where they kind of and you can associate redlining with race, because redlining, basically they took areas of the city, and they said they gave them a higher risk profile and discouraged people. I say people, I'm talking about white people, from buying in those areas, and the insurance rates were higher because they were considered high risk, and so it economically impacted those areas. But so she looked at those areas that were historically redlined in breast cancer, and found there was a direct correlation there too. And so it's very interesting to find, ask the questions, and that's what the research is all about. Asking questions. Well, why is it? Are there things? Is it socioeconomic? Is it race? Is there something about about the genes that get passed on from generation to generation that makes you at a higher risk? Those are very interesting questions.
You know, Dr. Izzard, when I was doing more research, and one thing I think that we even talked about this before,
Mm-hmm.
that a lot of times we might have cancer cells in our body, but our body has a tendency to be able to fight those things off. But
Mm-hmm.
then all of a sudden you start getting these cells that whatever reason they don't really kind of heal, and they start multiplying
Mm-hmm.
in a more massive rate. Can you speak to that a little bit for people that really, first of all, want to understand cancer, and then we can kind of talk about the BRCA1 and 2 gene that
Yeah.
African Americans a lot of times have challenges with as well?
Yeah. So cancer is um, a huge group of different diseases. So you have some cancers that are very treatable. You got some cancers that are very aggressive and they spread and they kill you. And so when we talk about cancer, it's really hard to talk about talk about cancer as a group. Now overall, historically, cancer deaths in general are down, and probably most of that is because we're better at screening for it and we're better at treating it. So we have
Yes.
chemotherapies and things. So fewer people are dying from cancers overall. Now, what we're finding is that there's certain cancer groups, like for instance, we found that we're seeing a higher incidence of colon cancer in younger people. But the number of deaths from lung cancer is going down, or breast cancer is going down. So it's hard to talk about cancer as a group, but generally what happens is cells in your body that normally are doing something, whether it's in your lungs or your liver or your ovaries or wherever it may be. Those cells for some reason start get genetic mistakes in there, and the normal signals in the cell, the DNA signal that tells the cell to stop dividing, actually stops working, and so that cell continues to divide. Now, in an ideal situation, if that happens on occasion, your immune system recognizes. Now, there are certain things that get expressed on the surface of that cell that say, "Oh, wait a minute, this cell's not right. This cell's continuing to divide." And it looks abnormal to your immune system, and your immune system will kill that cell. And so, that's actually one of the first lines against developing cancer, is that your immune system realizes something's not right, and it kills those cells. But for some reason, in some of those cells, they get past the immune system, and they move from being in your breast to now being in your bone. Okay. Well, first, usually it spreads to the lymph nodes. So it usually spreads from the area where the cell's supposed to be. And again, because your immune system is looking for these abnormal cells, it has to go through your lymph nodes. So your lymph nodes is where your immune system is kind of located. And so so usually that the first place it spreads to is what they call the sentinel node. So it spreads to a lymph node just beyond where that organ is, and then it starts growing there, and from there it'll escape the lymph node and it'll get to other parts of your body. So when we talk about metastatic cancer, like people tell me sometimes that we'll talk about family history, and they said, "Oh yeah, my mom died. She had lung cancer and breast cancer and brain cancer." Usually what that means is that there was a primary cancer, so maybe it started off in the lung and then it spread to her brain and spread to other places. So that's what they call metastatic. It's gone from one area to another area, and that's how they stage cancers too. So if it's still if it's within that organ, let's say it's a breast cancer, if it's still in the breast, then that's stage 1. If it's now spread to the lymph nodes, spread outside or at least spread to the surface of that organ, is a stage 2. If it's in the same region, so it's spread outside the breast, but it's still in the chest area, then that's a 3. And once it gets to other places, outside that general area, then it's a stage 4. And of course, the further it gets, the more dire the consequences of it. But yeah, cancer is very interesting in the sense that we don't know why the immune system is not recognizing these rogue cells. We don't know what's causing the genetic mistakes. So that's why people push things like antioxidants and certain foods that that are going to reduce. We think these free radicals, things that oxygen cells that are more attractive to other chemicals that are changing things and causing mistakes in your DNA. So maybe it's diet, maybe it's lifestyle, maybe even it's stress. But yeah, so cancer is again across the board. Can be anything from the most common cancer will be skin cancers, and most of those are benign. Melanomas are very aggressive and they spread. So it goes anything from that to something like pancreatic cancer, which usually and ovarian cancer. By the time we detect those, they usually are beyond treatment, and people die shortly after that diagnosis.
Yeah. We're going to take a quick break. This is Karen Dotson from the All of Us Research Program at the Medical College of Wisconsin. We also have Dr. Kevin Izzard with us today. He is a family practice physician and also a co-investigator of the All of Us Research Program and also chair of the Medical Society. Did I say that right, Dr. Izzard? I think
City Medical Society, yes.
yeah, Cream City Medical Society. So he wears a lot of hats and he sees a lot of things that are going on. And we're going to come back and have more conversation with him. I'm going to also let people know that if you want to join the All of Us Research Program and really become involved in research, you can call our number at 414-955-2689. That's 414-955-2689. And give us a call. Call us on WNOV 414-444-5253. That's 414-444-5250. We'll see you on the other side.
Vice President.
Any suggestions? Feedback?
But brain cancer, that's what I was like, what would simply, what would be the signs of that? Because that's, John Amos just passed on that.
Oh, for brain cancer?
You
Wow.
know, hear about breast and the other cancers, but
Well, one thing about it is like breast cancer metastasized is one of the number one cancers to metastasize.
really,
Yes. And so when they metastasize, it may go to the brain and they go wherever else. It's metastasized, going other places.
but Tesla, where does that mean?
It's going other places.
Okay,
It's more than one place.
wow.
But breast cancer is one that does that more.
All right. So this is the All of Us Research Project.
That's right. Program. This is Karen Dotson.
Host Karen Dotson, who's on the road. Where you in Georgia?
On the
Where are you?
road, but I'm with you. I'm with you. Right. We're right here together. Technology.
We're in
is wonderful.
spirit, right?
Yep. Thank you all for joining us this morning. I see that we do have some people online, so we welcome that as well. Just wanted to mention to people that we're at the table this morning. I always tell you to grab your coffee, your tea, your juice, because we're going to have some serious conversation. We're also going to be having some special guests coming on soon. That's going to be Keisha Jones and also Deb Nevels. So I want you all to stay tuned for that as well. Dr. Izzard, when we were talking about breast cancer, and you and I were talking this week, and I mentioned to you, I said, Dr. Izzard, I'm just curious about men with breast cancer. And you mentioned, you said, well, I really haven't ran across anybody. And I was like, well, I have, And so then I started really looking to see about this, because I think a lot of times men just think that it's just women. But I started looking at it, and it said that about 1% of all the diagnosis of breast cancer are men.
Yeah.
And then of those men, what got me was that it was Black men have a 52% higher incidence rate of breast cancer than white men. So here we go again. Okay, here we go again.
Yeah. Karen, this is the interesting thing about breast cancer in men. First of all, men don't expect to get it. So women are very good about, if they get a lump, if they get something weird going on in their breast, they think, okay, this might be cancer. I need to get in and get checked. And women are a lot better at accessing healthcare. So they're more likely to get preventive things done, like getting mammograms, that are preventive done than men are. So when a man gets breast cancer, usually it's more advanced because it's been there for a while. Because again, they're not expecting it, and finally they get in, and so now it's more aggressive. So the incidence of women's lifetime incidence of getting breast cancer is like 1 in 8. So 1 out of 8 women will develop breast cancer at some point in their life. For men, it's like 1 in 830 something, 833, I think. So it's so basically men are 100 times less likely to get breast cancer, than women are. So it is pretty rare. But when men do get it, it does tend to be, it has progressed further, and so they're up against the 8 ball, in that sense. And we'll talk about some of the differences. So men, when they have breast cancer, there's we talk about the immune system recognizing abnormal cells. Maybe I'll say this after we have because we got people on the line. Maybe we'll get to them first, and we'll come back to talk about breast cancer markers.
Good morning. This is Karen Dotson. You're at the table this morning?
No. No. I guess Debo's saying we don't have anybody.
Okay.
Yeah. Let's talk about markers then.
Yes. Let's talk about
markers. Part of the way your immune system recognizes yourself is that you have these proteins that are on your cells, and it's kind of like a passcode. And when your immune system sees these markers, it says, "Oh, okay, this is me. This is normal." And then it sees something that's not supposed to be there, and it says, "Whoa, okay, either this isn't me, this isn't my cell, or this is something else you need to get rid of." So your immune system kills it. So those are called antigens. Those markers. So there are certain antigens that we find that when people have cancer, in this case breast cancer, there are certain markers that they make, and those markers are, when you're talking about ways, okay, how do we get rid of cancer? Well, we talked about your immune system sees that and it gets activated and says, okay, this is not self, let's get rid of it, kill it. We can make medications that will also recognize those things, okay, and maybe are able to target those cancer cells. So, because the problem with cancer is that we're trying to kill off those cells, but we don't want to kill off our own cells. But those cells kind of came for us, so we have to find some ways that those cells are different so that we can target them. Now, with chemotherapy, the idea is this. So you got cancer, it's growing rapidly, it's spreading. So with chemotherapy, you say, okay, let's just kill all the rapidly growing cells. So we give you something, and guess what? Rapidly growing cells include cancer, but it also includes your hair. It includes your GI tract. So that's
and good cells too, right?
What's that?
Will it be good cells too?
Right, exactly, right, yeah. So it's killing off good cells too, and that's why people lose their hair, because you're killing off those those hair cells. You're killing off the cells in your GI tract. So now you're getting vomiting and you're throwing up and all these. So those are all the bad side effects are coming from, are kind of unfortunately a byproduct of using the chemotherapy. So you want to target it to killing just those cells without killing your normal cells. And so that's what all this, the research in cancer treatments is, to try to find medications that will treat cancers, but not kill off your healthy cells. And so when we talk about precision medicine, is that not only do you want to get, you want to get even more targeted. So in the future, in fact, we're at the time now where when they do the biopsy of that cancer cell, they'll be able to analyze it, and they'll say, okay, this cancer is more susceptible to this medication. And this cancer is not as susceptible, but this other medication works better. So we'll be able to target better the medication that's going to treat that cancer without killing your other cells. And, in essence, without causing, bad side effects, because that's the worst part about the chemotherapy, is that it's killing off your immune system, it's killing off your hair cells, it's killing off the GI tract, and so people feel terrible. But with breast cancer, these cells have hormone receptors, and so they're most of them. Well, not say most of them, but a lot of them have receptors for estrogen. So the idea is this. So if you can find a receptor on a cell, that receptor is feeding that cell. So the idea is you want to starve it. So if a cancer cell has an estrogen receptor, you can give medication to block estrogen and in effect kind of starve the cell, the cancer cell. Now, of course, you're going to kill off other estrogen areas of your body, but you can deal with that. At least you're not killing off everything. Progesterone is another receptor that they can target, that's starve off the progesterone. So, and then there's a gene that well, again, kind of go back to the genetics of it. There's HR. Why am I thinking my name now? There's HER2 gene. That's what I'm trying to think of. Okay. So HER2 gene is again, going back to research. This is something that we found that women who have breast cancer tend to have this HER2 gene, and HER2 makes a protein on the cells of some of these breast cancers. And so again, it's another area you can target. Now, the really bad cancers, and these are the ones that, of course, Black women are more prone to getting, are cells that are negative for these receptors or these proteins, these antigens. And so we call antigen negative. And then the really bad cases that have to be triple negative. So of these proteins, they don't have any of the big three that are used to target those cancers. So in essence, you got a cell now that has a brilliant disguise, because there's nothing to kind of identify it for us for how to treat it.
And that's the purpose of really having research. Mm-hmm. The importance of it is that when we have people that volunteer to be a part of research, it allows for researchers then to see maybe what worked well for certain people, what treatments worked well, and which ones didn't. And so when you join the All of Us research program, we collect different types of questions and surveys from you. Then we also request your biosamples, and we request your electronic health records. And That information goes into a system. It keeps it all very confidential. It's not all together. It goes to different places. But researchers then can pull the data. And that's what we really want to do. We want to make sure we have that. And
Right.
from that, they're able then to start figuring it out. And that's why Dr. Iser's talking
Mhm.
about precision medicine.
Right.
You
And
know,
it's not
go
only
ahead. Yeah.
right. It's not only women that have cancer, but if you're in all of us, someone might look at at people who have relatives. So they might be looking at, do you have a first degree relative, a sister, a mother who's had breast cancer, and then what things do women who have developed breast cancer have in common? So it may not be just after you get it; it may be trying to predict who is more likely to get it. And so you might follow a group of people, let's say women who have a first degree relative, who's had breast cancer, and then you're looking at what's happening over their lifetime. What kind of things are they, can we gather? What kind of information can we gather from them? Like what are they eating, or what's their stress level, or where do they live, or those kind of things are, it's not just for people who actually have breast cancer, but we're looking at people who are healthy and maybe are at a higher risk for developing.
And that's one key area as far as with the All of Us research program, that we ask like environmental questions.
Mm-hmm.
Like, do you live in a city? Are you rural? Do you live in an apartment? Do you live in a single family? It's all those things that play a role in our health. And so when we're asking all those questions, when Dr. Iser's talking about that, they're trying to pinpoint like where's more affecting, African American people than everything else, and I think a lot of times it might be stress, because we have challenges a lot different than other populations. And so, that also plays a significant factor on it. But, when Dr. Iser mentioned about people joining the program and their family members, there's over 38,000 participants right now in our program. And this was actually data from last year, so I know we have a lot more. But we had over 38,000 participants that said their family members had cancer. Well, the question is, okay, your family members had it, but maybe you don't, or maybe you might have a gene that you're carrying that later on you might get to know you have it. And so these things can be detected by research as well. Am I correct on that, Dr. Iser?
You are correct. Yeah. Hey, Karen, we have a caller on the line.
We do. All right. Caller, thank you for joining us at the table. Good morning.
Well, and thank you for accepting me. Good morning to you.
You're welcome. Good morning.
Good morning, Dr. Izzard. We have Kevin or Tito this morning?
This is the original Dr. Izzard.
Well, when it comes to the bloodline, everybody's original. It's like identical twins and not identical. But you're still twins, but not identical.
Yeah,
but,
Tito's my younger brother. Yeah, so I call myself. I was the original Dr. Izzard. He came
You came first. That's right.
I love and respect both of you. Good morning, Ms. Dobson.
Good morning.
Good morning.
Good morning. Welcome to the table. As we say, if you're not at the table, you're on the menu.
Yes, sir. Yes, sir. Thank you. Good morning, Milwaukee. Tyrone W. speaking. Good morning, Mr. Debo and Mr. Carvey. Well, you were speaking about the chemotherapy and the genes there, and it made me think once again about, to kind of double fold for both male and female, but let's take the female first with the breast, and then the chemotherapy. Then I'll just run them both, rapid fire back, so you have to kind of remember the breast cancer, and then how it affects the genes, and then the female reproduction as far as the eggs, and then as far as the male, the testicular cancer, and the effect of the sperm. Then, when we're talking about genes and cells, then because sperm is a cell because it carries your DNA, from generation to generation. So that's a cell. That's your DNA.
Right.
So yeah, your sperm has everything in it that from everything before you. Both mother and father side. So how does chemotherapy affect the onset of the off balancing, or the sperm, as well as how it may affect the eggs? Then, and I'll listen to you over the air. Thank you very much. Have a great day and a great weekend.
All right. Thanks for the question. And probably as you would expect, again, chemo's killing off rapidly growing cells, and so now the interesting thing about women and eggs is that women stops making eggs before she's born, and so by the time you're born, you have all the eggs you're going to make the rest of your life, and they mature and you release one a month when you hit puberty, and until you reach and then you get the menopause and you stop releasing those eggs. But you have all the eggs you're going to have for your life now, and that's one of the reasons why women who are older have a higher risk of having genetic issues with those eggs, because they've been sitting around for 30 years, 40 years, and so they can develop mistakes. Men, on the other hand, make sperm their entire life, and so but as you can imagine, if you have chemotherapy, you're probably going to kill off all those cells, and so that's one of the things that a lot of people will do if they want to have kids is, and they discover they have cancer, they might want to get that egg, they might want to harvest those eggs while they can, and so they don't kill off everything, because once you kill it off, it's not coming back. With men, again, you can continue to make sperm, but during the time, of course, you're not going to be making any live sperm. So yeah, chemo is going to kill off anything rapidly growing, including egg and sperm. Another thing that's kind of interesting about this thing is, as we go more into it, is that rapidly growing cells are, could be things like you're talking about hair and skin and things like that. Viruses, and this is very interesting. So what a virus does, of course, is there's even a question about whether viruses are even living, because viruses are just these balls of protein with DNA or RNA in there, and they can't reproduce on their own. Viruses need to have a host cell. They need to have an animal cell what has a cell nucleus and has all those things that can make more cells. So what a virus does is it hijacks a cell and tells that cell to stop making its own cells and instead make virus parts, and that's how the virus spreads. And so but the interesting thing we find about cancers is that, like, for instance, there's a virus that a lot of women have heard about called HPV, human papilloma virus. Okay, that virus can cause things like warts, but one of the more interesting things that it does is that in the cervix, it can if it gets into your cervix, it can actually tell your it makes those cells grow rapidly, and it causes cancer. So one of the leading most common reasons for cervical cancer is an infection from this HPV virus. And so talking about cancer, well, one thing we found was that, okay, well, it's a virus that's causing this cancer. What if we immunize people against it? And so there are vaccines that we recommend in kids. Now you want to vaccinate the kids before they become sexually active, because by the time they get the virus, that's already in your system. So we want to vaccinate kids against getting the virus, in particular girls. And that way, if they don't get the virus, then they're less likely to get cervical cancer later on.
Dr. Izzard, that is so true, because when I was working with a youth program some years ago, that was one component that we were really talking to the parents about, especially, with teenagers. And what age are you talking about for them to get this vaccine?
We're usually talking about 10-year-olds and 12-year-olds.
That's what I'm saying, real early. And some parents don't want to say, "Oh no, my kids are not having
a conversation." My baby is sexually active. And the idea is before they become sexually active.
That was a big challenge that we had to work with parents on. But the benefits are just phenomenal as far as later on down the road for them.
Right. So 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 that's an example of a treatment, to prevent cancer. So you get vaccinated against HPV. Now, other thing too that's different is that we're now able to detect that virus, very cheaply and easily. So when a woman goes now for her Pap smear, instead of, because what a Pap smear basically is a screening for cervical cancer. So we're sending cells off. It goes to the lab. They're looking for abnormal cells. If the cells are abnormal, then they might have to go back in and do a colposcopy, which is basically a biopsy of the area looking for cancer cells. But we're getting to the point now where we know that women who don't have the HPV virus have a very low chance of developing cervical cancer. So actually, recommendation now allows for us to just screen for the HPV. And so if you don't have HPV and you're over 30 and you've had normal pap smears, then we can just actually screen you for HPV and not even send the cells off, and you're good for 5 years. It used to be that we do those every year. And now if you're HPV negative and you've had normal pap smears, you can go every 5 years on your pap smears.
You know, Dr. Izzard, you are like a walking encyclopedia.
Yeah,
I mean, I just
every day, you know? Yeah, this is what I love about family medicine, because it's never boring. So, you know, I see adults, I see kids, and actually until recently I delivered babies, and so I don't have the depth of knowledge that a specialist would have, but I have a breadth of knowledge. I have to know about a small amount about a lot of different things, and so because you never know what's going to come in. And, you know, we're kind of, as primary care doctors, we're the first line. So someone comes in, they got a question about something, or, you know, they come in for the annual exam and you see something, you know, you need to let them know, you know, what things are important, what things are important, are not important. And then where do you go? You know, what happens once you're diagnosed with something? So we kind of walk with them, you know, through the process. And I think Deb's going to be talking about that later, you know, the after breast cancer diagnosis. You know, ABCD, what happens to these people and how do you help them through, like this woman I talked about when I started off the top of the show, my patient with, you know, with breast cancer, now that's stage 4 and did not respond to alternative therapy. And now, well, interesting thing with that was that she was seeing this alternative place in California, and when she was first diagnosed, she saw an oncologist here at one of our local health systems. And the oncologist was offended because she wanted to seek an alternative treatment. Now, I can understand. So he was frustrated because he has the treatments that we normally do, and you know, he's got this algorithm we follow, and so she wants to work outside of that. And people feel, well, if you're going to do that, I'm not taking responsibility for what happens. In this case, he happened to be right. You know, so she had an outcome that, you know, was not expected, or not a question. Could it have been prevented? Who knows? You know, and maybe it could have been had she done something more aggressive and more, more mainline instead of going the alternative route. But she came to me because the oncologist would not order the PET scans because he said, I don't want any part of this. So, you know, you go see your primary doctor if you want a PET scan to follow up for this. So that's how I got involved. So I was ordering her PET scans and giving her injection, her anti-cancer injection. So, you know, we were doing that. And again, unfortunately, and then working with the alternative place that she was doing working with in California. But now now this has gone off the rails now. So now she's back working with a traditional oncologist. But yeah, so I kind of am involved in all those, you know, that treatment care on different levels. And I completely believe that it's up to the person, you know, especially when it comes to things like cancer. I can't tell you what to do. I got a couple of family members right now who are actually, both of them are dealing with lung cancer. And, you know, so people want to do things differently. Some people want everybody to know and, you know, and pray for them and be with them. Other people want to do it privately. You know, some people, you know, might decide now, you know, with cancers, the way we treat cancers are either you're going to do chemotherapy. We talk about chemo and all the side effects that goes along with that. Either you're going to do chemo, or you're going to do radiation, or you're going to do surgery. And you might do a combination of those things depending on what cancer it is and where it is. And so people have to make a decision. So if you tell me I got, you know, 6 months left of life, if we do chemo, we can get you out to a year. But you're going to be sick. You're going to be sick for, you know, most of that time. Some people might say it's not worth it. You know, if I got 6 months, let me be happy for my 6 months. Let me eat what I want to eat, you know, and live my life and, you know, have my 6 months. Some people might say, I'm waiting for my daughter's wedding, you know, and she's going to be married. And so I want to get out to that 1 year because I need to be around for that. And so you're willing to deal with the side effects of chemo. So it's a very personal thing. So I strongly feel that you support people, and and when you get to that point, you have cancer. It's not about me, it's about that person and what they, what works best for them, something they sit down with their family, and their religious person and their, and their doctor, to have a conversation about what they want to do.
You know, what I like about what you mentioned, Dr. Izzard, is that you work with that person. So
Mm-hmm.
you take that individualized approach, so you're making sure that that person feels comfortable and that you're going to work with them. Like, I really think that was wonderful how you mentioned that you work with one of your patients, even though she wanted to do the alternative. And now you're still working with her now.
I'm still working it out, right? Yeah. I mean, so why would I get offended by that? And I know enough about medicine to know that we don't have all the answers, especially with things like cancer, where there's a lot of research being done, a lot of new findings that we didn't know about, a lot of treatments that we had in the past that are changing, and so you can't be too dogmatic about it because we don't know everything about it. And there's a whole huge component of people. Everybody will tell you about somebody who had cancer. They told them that they had 6 months left, and 3 years later they're still going. And so you can't tell people that you're definitely going to die, or that. Now they do a pretty good job of predicting how much time you have, but it's not absolute. And so people want to take that chance.
Yes.
That's them.
Yeah, we're going to be right back, Dr. Izzard, with you, as well as we have Deb Nevels. She is the program manager for community outreach and engagement for the Froedtert Medical College of Wisconsin Cancer Center. And then also we're going to be having another special guest that you all have not talked with and heard from, and that's going to be Keisha Jones. She's the Director of Healthcare and Community Partnerships, ABCD, after breast cancer diagnosis. So we're going to have some interesting, really hot conversation. So I'm going to ask right now, we're getting ready to take our break. If you can join us, feel free to call us at 414-444-5253 or 414-444-5230. We'll see you back on the other side.
Good morning, Dr. Lynn. How are you?
Okay, how are you?
I'm good. I'm looking at MC right now. He's terrible.
He's sleeping, yeah. I know, I was worried about him.
I thought he was going to when I saw DEG yesterday. Do you see that central stuff? I saw Dr. Black had called that central rhythmic stuff he had. I haven't finished looking at them, but I saw, I guess those are seizures in that central area. Did you see it?
Or tell me what time.
I just marked a couple of them now. 0017, 0113, 0117. I marked a couple. I know Dr. Black had called them seizures, and at first I thought it was really rhythmic, but I wasn't sure if I wanted to call it a seizure. But I went on and marked it because she had marked some of those yesterday. So
I'm calling him up now.
I'm still looking at them. So yeah.
He basically, I think he's had like 4 seizures since 6 a.m. So I let the team know, but
those were subclinical too. So
No, the ones like from 6 a.m. to now, they're all clinical.
They're clinical, okay, yeah, the central stuff is, plus one.
Okay.
Yeah,
Yeah, so, let me see, 17, you said?
yeah, 117.
Oh, 117.
Did you see that resident in the central area? Yeah, no.
I was kind of like all over.
I know, so I was real questionable about it, and I was trying to look at Dr. Black's report, and she calls him, so. So I don't know if I want to call those. That's what I'm asking you. See what she-
Yeah, I mean, I didn't really think there was anything around there that was.
Deborah Nevels, who's another old classmate of mine. And we're talking about breast cancer. It's Breast Cancer Awareness Month. And so we're going to answer your questions about breast cancer. And in the second half, we're going to talk more about what happens when you find out that you've been diagnosed with breast cancer. Because, again, you hear that C word, and there's so many different options, so many different ways you can treat it. And how do you negotiate? How do you move through that whole system, that very complicated system of you have your surgeon, you got your oncologist, you got your radiologist, you got your primary doctor, you got all these people that you might be going to, including getting medications and injections and other therapies, and it gets very, very complicated. And for people that are already overwhelmed, now you got to maneuver this system. And so Deborah's going to talk about the after breast cancer diagnosis treatment. And so what do we do with that? So Karen, you back?
I am here. And Dr. Izzard, one thing that you mentioned that I would like for you to speak on, and I want to say good morning to Deb Nevels. It's always good seeing you. Thank you for joining us at the table. We love to have you, and you always bring us so many special guests.
Oh, thank
Dr.
you.
Izzard, medications. I always see that a lot of times when people are suffering with cancer and breast cancer, and when it starts metastasizing, and they have so many different types of medication. It's one medication do this, and the other ones is to help this one do that, so it don't affect you here, there. Explain to me, why is it that a lot of times they have so many medications?
Well, one is you're trying to treat the cancer, but we talk about side effects. So you take chemotherapy, and so you're taking a medication like methotrexate. Methotrexate will kill your cancer, kill rapidly growing cells, but it also causes other deficiencies. So you might need to take some other medications to kind of make up for what you're missing because of the chemotherapy. In other words, like any other medication, it can affect your electrolytes, and so you might need to take a supplement like vitamin K or potassium or other things that are going to kind of make up for that. In some cases, you're treating side effects. So it's causing nausea and vomiting. You're taking something to treat that. And then also you're trying to get healthy too. So you might be taking medication too to kind of promote your immune system. They kind of make up for what you're missing there. So yeah, you could be on a lot of medications anyway, but especially after you get cancer, you might be on medication. And then some medications, depending on what they're doing, if they're basically killing off your immune system, you have to really be mindful about getting sick. And so you might be on medication to prevent you from getting infections and getting sick.
And, another thing that I notice a lot of times when people are going through treatment or people that are challenged with cancer is that they lose appetite. What's that all about?
Yeah, and that's going back to your thing. So your mouth has rapidly growing cells, and so you basically kill off your taste buds.
Really?
And, that and the fact that you're not
so food just doesn't taste good. I noticed that with people when they're challenged with cancer.
Right, and that's why. And then there's a thing called with these cancer cells, especially when your immune system starts to kill them off. There's these things called cachexins. They actually tell your brain that you're not hungry, and so that's why they become cachectic. They start withering away because one, they don't have an appetite, they're not eating, and there's also something about these proteins that are kind of making your body waste away. And so people will start losing weight. That's actually one of the first signs of cancer, one of the early signs of cancer, is that people will start losing weight unintentionally. And so if you ever have that situation where you're losing weight and you're not trying to lose weight and you don't know why, then you need to really see your healthcare provider to make sure that we screen you for cancers, because that's one of the causes, that things that can cause you to lose weight unintentionally.
Yeah, that's always been so many challenges for people with cancer, and I always wonder, like, why don't they eat? Because they know they need to stay healthy, and then they just don't want to do it. And I thank you for explaining that, so we can, so that a lot of times it's just better for people to take more different types of. Some people do protein drinks, they do, some other things. What do you recommend?
Oh, whatever works. There's a medication that's megestrol, which is it's a hormone that increases your appetite. So people might be doing that. So you're gonna laugh when I say this not here, but marijuana is gives people the munchies. Well, some people with cancer finds that it helps increase their appetite. So
oh wow, okay. Because I know they do have that. Sometimes they recommend, in different states, especially. I noticed some cancer patients, they will really kind of feel like they need that. And so I'm glad you explained that to us. So sometimes it works out a lot better.
For medicinal purposes, not for recreation.
Okay. Yeah, that's good to know. That's good to know. Dr. Izzard, I know the time is starting to really wind down for you, but what do you want to tell the community today related to breast cancer? This is Breast Cancer Month. We know that not only women, but men also are challenged with it. What do you want to tell us today as it relates to that for this month?
Well, there's two things. One is be aware of your breasts. Some women have bigger breasts, some women have smaller breasts, some women have lumpier breasts. So you need to know your breast. You need to know when something's there that normally isn't there. Your breast might change throughout the month. So it might be lumpier during your menstrual period and not as lumpy later on. So you need to, if you do you're doing your self-breast exams, shower and checking things. It's always good to note kind of, okay, this is what my breast feels like after my menstrual period. Okay. And so be aware of that things are changing. So, so again, despite what I said earlier about the the value of doing self-breast exams and finding more benign lumps, it's better to deal with a benign lump than to miss a cancer. So, I'm still saying, go ahead and do your breast exams. See your provider if you find something abnormal, indentation, a dimple, swelling, rash, nipple discharge. Especially check under your lymph nodes. Like I said, cancers will spread to the first lymph node. So in your armpit, are you feeling a swollen lymph node there? That also might be an indication. So, particularly pay attention to that. That's called the tail of your breast. So, pay attention to that area, and then get your mammograms. Some people get busy and and understand they get busy, but and some women just feel uncomfortable, getting that compression with the mammogram. But get your mammograms. And insurances have to cover it, so you shouldn't be getting billed for it. If you have trouble getting a mammogram for whatever reason, let's say you don't have insurance, again, the Affordable Care Act mandates that insurance companies have to cover screening tests like mammograms and pap smears and things like that. There is a program with the state, the Well Woman program, that will pay for you to get those things done too.
That's wonderful. And for men, what do you have to say for them?
Men, just be aware that you can get breast cancer. So if you got a lump in your breast, don't keep putting it off. Get it checked out, because just like women, it can be treated, it can be detected, and so and men, actually, breast cancer in men tends to be less aggressive because they tend to have those antigen receptors on theirs, and so they can be treated. But where men really get into the hole is that they wait till it's too late, till it's spread already.
Wow. That's good to know. So, and what does it look like for men? Is it similar to what it looks like for women?
Yeah.
Okay.
Yeah.
So,
and it's in some ways it's a little more difficult because, like, as far as like surgery goes, with women, because they have bigger breasts, you got a lot more material that you're dealing with. But for men, because you don't have as much things that, as far as fat and other things you're dealing with in that area, then, trying to do a flap, when you remove the breast, it gets a little more challenging, but, it can be done.
Well, thank you, Dr. Izzard, for
Okay.
taking the time to tell us more about cancer, breast cancer, and the challenges that we have. We thank you. This is we have Dr. Kevin Izzard with us. He's a family practice physician, and he is really a wealth of knowledge, and we really appreciate every 2 weeks that he sits down at the table with us. So we want to thank you for that,
Yeah.
Dr. Izzard.
Yeah. And Karen, you stay safe.
Okay, thank you. And Deb Nevels, good morning. We have conversation going on, Deb.
Yes.
We have conversation going on related to breast cancer, and you really are heavily involved in the community to really get our people, our community, our women more knowledgeable about breast cancer, and also our men. So, Deb, give me or tell the community some of the things that you are doing, or all the things that you are doing, because you do so many things, but you're so involved in the community. But just really want the community to know what you're doing this month for Breast Cancer Month.
Sure. We are extremely busy. So there's a lot of churches that are having events on the weekend. This weekend at Christ the King Church, I have to look at my calendar. I think we have 4 churches having events this weekend. So Christ the King Church, they have an event that's going on, and they will have screenings. So Dr. Izzard had mentioned the idea about learning more about your breasts and learning how to examine them. And what's beautiful, there is an organization out there called, and I apologize, Christ the King is not this weekend, I think it's next weekend, but there's an organization, Nurses Affecting Change, which is an arm of the Black Nurses Association. These are nurses who teach you how to do your own self-exams. And, when we go to the doctor and they do the breast exams, it's, very quick. And with Nurses Affecting Change, I always tease them. I'm like, after you do your breast exams, it's almost to the point, you owe me dinner or something, because it's a long
Oh, you did it up.
dinner. But
that's a good one. I have to mention that.
I'm sorry. Look, they'll get me later, but yeah, it's a process where they test it in doing the exams, and then they teach you how to do it. So what you normally get in a doctor's office might be, a 5-10 minute exam. They can spend 20 minutes depending upon what questions you have, but they will teach you how to do that self-exam. And so there's an event, actually, Pink Shawl Initiative, which is it's a initiative for individuals who are Native or Indigenous. They are having an event this weekend at the American Indian Council on 65th and Layton, and the Nurses Affecting Change will be there. Also, let me see where else. No, at next weekend at Christ the King, they have a Women's Health Check Resource Day that's occurring at Christ the King. And so that event will also feature clinical breast exams. Mount Zion Healing Temple, right up here on Green Bay and Capitol, kind of behind the Burger King, keep going past Burger King. They are having an event there. And not only are they providing clinical breast exams, but they are also doing, Dr. Sandra Underwood will be there and do a presentation. Yeah, doctor, that's my doctor. I love her. Dr. Underwood is a nurse. She is one of the founders. She and Bonnie Anderson started this clinical breast exam program. And so that's one piece. On the 13th, which is Sunday, Community Baptist is having a health fair. On the 19th, there are several events, but one of the things that is really critical, Oza Holmes Breast Cancer Support Group. Now, this is a support group for individuals who are African American and have been diagnosed. At first, they started off with breast cancer, but now they do all cancers. So anyone, men and women, are both welcome. But they're having their annual breast cancer awareness program, and that's at 11 a.m. at St. Joseph's Hospital in the auditorium. And that's going to be a really informational opportunity. And then on October 26th, if you have not been there, now's the time to get there. Thrive On at 9 a.m. We are doing a education around multiple myeloma, and Dr. Izzard mentioned myeloma being one of those that's kind of difficult to diagnose, also difficult to treat. We will have several doctors from UW-Carbone and the Medical College of Wisconsin that will be talking about multiple myeloma in the African American community specifically. And what we're looking at is health equity and access to care. So that one again is on October 26th. That will be held at the Thrive On building on Thrive On King. Parking is free. The event is free. But definitely something that you need to go to and learn more about multiple myeloma and other blood-borne cancers. That's a
When
blood.
you say myeloma, tell
Yep.
people, what is it? What type of cancer is that?
That is a blood cancer. It's a rare disease, and now you're going to test my knowledge.
Well, you know it.
Look, I'm trying, but yeah, it is a rare blood cancer disease, and it is difficult to detect. Oftentimes, there might be something where someone gets a bone fracture, and that might be what indicates that there's something wrong. But it is difficult to diagnose. We often go past and don't think about it, as Dr. Izzard was talking about. We don't get the screenings, we don't talk about it, and if it's something that we can just take a pill or take something and okay, the pain's gone, that's one thing. But with the incidence of multiple myeloma, what's really important is that African Americans or Black people have a twofold higher risk of developing multiple myeloma than whites. And the diagnosis is something that if you don't treat it, don't identify it early, Black people that often have the disease, it's usually diagnosed when it's more advanced. So it's we also have a higher risk of we also have higher rates of anemia, hypercalcemia, and renal failure. And so there's things that occur with our blood that puts us in a higher risk factor, and also a higher risk factor of not being diagnosed early. So it's really important.
That is so important. And that's why we have programs like the All of Us Research Program for people to get involved, so that way you will know what's kind of going on with your health, but not only you, but also researchers, because I keep always wondering, why is it that it's always us with these high numbers of disparities of health, and so that's why we need to be involved in the program. And I'm just going to, just shout out to you, Deb, for all the work that you're doing. But I also want people to know that you can call or you can go to joinallofus.org to sign up, so that way you can actually get reports back related to your genetics. And this is going to be free information to you, and you don't have to pay for it. And so that's what I love about this program. But you can also call us at 414-955-2689. That's 414-955-2689, that you can get involved with this program. Now, Deb, you told us a lot of information about cancer and about all these programs that are going on. And for people that didn't have their pencil and paper with them, can you tell them exactly what we can do to get this information from you at another time as well?
Yeah, so definitely at the if you go to the MCW Cancer Center website, there's some links there where you can actually, if your church is having an event or your organization's having an event and you want education there, and we partner with all of us. So it's kind of like if you get us, you get a whole group of people. So we bring in more people than just ourselves. And there's a link there where you can ask questions. You can also reach me directly, 414-955-2364, and I can give you information.
Repeat it again. I want to make
Yeah,
sure.
I know. I go so fast.
Yeah.
414 955 2364. And also, if you're on Facebook, the Cancer Center has a website. All of the flyers for all of our events are on that website. So you can go to our Facebook website and you can get the information also.
And what is that Facebook website? What is it called? What's the name
It's
of it?
MCW Cancer,
MCW
Cancer Center. Yes.
Yeah, so then we can get information. And and I'm drilling Deb on all this because guess what? She has so much going on that you all want to really get involved and know. And also, Deb, for churches and different organizations that want you to help them coordinate something or to help you bring a team of people in there for their special event, they can also reach out to you as well.
Yes, please. You can reach out to me and we can definitely, I say the beauty of it is that if I don't know, I can definitely call some folks and find somebody who does know. Working at the medical college, people have called me and said, we want somebody to come and talk about diabetes or hypertension or nutrition even. We also have most recently or later this month, I think on the 19th of October, there's an event at UWM from the African American diaspora is putting on an event, and we have a therapist that's actually going to talk about stress that is going to be at that event. So there are a lot of resources at the medical college, and part of what we are trying to do as a college is bring those resources back into the community. So please reach out, and like I said, it doesn't have to be me. As a matter of fact, I'm trying to deploy others and give them opportunity to go out into the community. But yeah, there's definitely an opportunity for people to go out into the community and for us to get our speakers, and we have docs that love to be in the community.
We really do. That's one thing I love about the medical college in Wisconsin. They're like, just let me know where and when, and they're going to be there. If not, they're going to find somebody for us, right?
Right, exactly. And I don't want to get away from our nurses. Our nurses, because I'm at the medical college, I'm also connected to Frederick Health. So not only our nurses, but also I had an event year before last, where the financial navigators from the Cancer Center, they are individuals who help once you're diagnosed, if you want to know what's going to be covered or what options do I have for coverage. Our financial navigators were interested. They came out to talk to the community. Our social workers, our nutritionists. There are so many people that are doing such good work, and they just want to get out in the community.
And that really says a lot about what we believe in, because we really have a really large and nice, strong office by Dr. Stacy Young for community engagement for the medical college of Wisconsin. You kind of like fit under her umbrella too as well, right?
Yes, and it's such a blessing because everybody knows Dr. Young, and so she's well known in the community, has an incredible reputation in the community, and we're connected with her and the Office of Community Engagement as a whole for the college, and so that we partner very closely with them to also be able to try to find resources when people ask for us. And that's actually the event that we're doing with UWM. It came through the Office of Community Engagement. We worked collaboratively to get a speaker for that.
That's wonderful. We also have, and I've been waiting to talk to this young lady, Keisha Jones. We have Keisha with us today. Am I correct on that, Deb?
She is not here yet.
Okay. I was hoping that she would be here. But
she is here. I'm sorry.
Okay. I was thinking, yeah.
She didn't walk in the room. Come here.
Come in. Yeah. Okay.
Table, Keisha.
I see you guys miss me, don't you?
I do. I had no direction. I was so lost. But I want to tee up. If I can tee up Keisha, because I love this woman. She is incredible as she comes in. Busting at me.
I was reading her bio that you sent to us, and it was so awesome when I was just reading all the things that she's doing and what she's experienced and what she's gone through, but how she believes in empowering the community. And so at this time, I want you to introduce Miss Keisha Jones.
Yes, Keisha is a jack of all trades. This woman does so much. I don't know how she does it. She is. I've known her for a while. She is the president of Sisters Network of Southeastern Wisconsin, which is an organization for African American women, and she'll who have been diagnosed with cancer. Plus, those I'm a member and I'm an ally. I like to think, and a supporter, and I do what she tells me. And then she also works for ABCD, which you heard us mention a couple of times after breast cancer diagnosis. And Keisha has her own journey story, which is incredible. And here's Keisha Jones.
Yeah, Keisha, welcome for joining us at the table today. Keisha, and I think that we're going to have to kind of move the camera a little bit so people can also see her as well. There you go. Thank you. We want to make sure we see that beautiful face. Yes.
Thank you. Good morning. Good
Good
morning.
morning. Thank you for joining us at the table today. And kind of briefly tell me, Keisha, what has been your journey? Give us a nice background of you.
Yes. So my journey, and thank you, Deb, for that wonderful introduction and just the opportunity just to be here and share, especially during Breast Cancer Awareness Month. My personal journey, being diagnosed with breast cancer at the age of 46, just after a regular mammogram, and then having to be called back to do some additional testing. It was discovered that 7 tumors were found in my left breast. Thankfully, it was caught early, so I was diagnosed with stage 1. Lots of terms here, but stage 1 ER positive, HER2 negative breast cancer. And the reason I want to say those specific diagnosis is because I believe, as you'll hear in my story, that it's so important for women to know the type of breast cancer that they have, and not just a general diagnosis of breast cancer, but it's important for them to know. So I was diagnosed with ER positive, HER2 negative breast cancer, was able to do a lumpectomy, which is basically removing the tumors, a surgery to remove the tumors out. And then I opted for reconstruction of both breasts. And like I said, it was caught early. So I was able to go through a pretty simple, I guess, standard of care and treatment, and only needed radiation and didn't need chemo at that time. Was able to ring the bell, tested negative for BRCA, which you will hear a lot about, BRCA testing. And so for me, you would have thought that was the end of my story. I did the radiation and I was able to do some hormone therapy by taking an oral pill, which would help lessen my reoccurrence. When you go through a breast cancer diagnosis, of course, it's hard to hear those words that you have breast cancer. And you really need that support system. And you really also need to advocate for yourself and need understanding. So going through that, I did all the things that I was supposed to do, being told that if I did radiation and took this pill for the next 5 years, that my reoccurrence rate dropped down to 11%. And so I had been in remission for 4.5 years after ringing the bell. However, in late December of 2022, really noticed some excruciating pain in my right shoulder, and thankfully didn't just dismiss it. My first call was to my breast oncology team, and they started running testing. And by early January of 23, I was re-diagnosed with stage 4 metastatic breast cancer, because now the cancer had spread to different parts in my bones and a little on my liver. So thankfully, I am in very good hands with, I guess I can say, my team at the Medical College of Wisconsin, and very stable thanks to, science and research and being able to have some additional testing that is not always offered up front to women. So that's why it's just so important to know what's going on in your body, to speak up and to advocate for yourself. So,
Keisha, we thank you for sharing your journey. We're going to be right back in a few minutes, so I want everybody to hang tight. You're at the table with Karen Dodson from the All of Us Research Program, Deb Nevels, and also Keisha Jones. Feel free to call us at 414-444-5253, 414-444-5250. We're going to have more conversation related to breast cancer. And we really have an expert here, not only experienced it, but also is doing something to work with the community on it. So please join us back on the other side.
We're in this love together.
Republican Senate candidate Eric Hovde showed up to the Milwaukee Juneteenth Festival. He said he was having a good time.
I'm here having fun. This is one heck of a party.
But then Eric Hovde was asked if there was anything he was going to take away about Black culture. Hovde's answer?
Look, I've spent a lot of time in Black culture. I've spent a lot of time in places like Africa because I have homeless shelters.
Run that back for me? Eric Hovde is asked about Black culture, and the first thing that comes to mind is taking trips to Africa and homeless shelters? Hovde's comments were called, quote, ignorant, and they reek of stereotype and white paternalism. But when Eric Hovde was asked about the criticism, he said, do I have to respond to the stupidity of that question? Eric Hovde.
So I've spent a lot of time in places like Africa.
What's wrong with this guy?
I'm Tammy Baldwin, running for Senate, and I approve this message.
Paid for by Tammy Baldwin for Senate.
Come on out to Rain for First Friday, October 4th, 5:30 to 9 p.m., located at 231 East Buffalo Street. Are you looking for a new place to go? Something grown and sexy, where bosses mingle to promote their business, feel supported, and meet new people? Then you want to go to the First Friday Business Mixer to engage, elevate, and expand. The National Executive Network and the Wisconsin Black Chamber invite you to the monthly First Friday After Work Party. If you have a business to promote or an idea to launch, the First Friday After Work Party is where you want to be. That's at Rain Event Lounge, and it's free. October 4th, 231 East Buffalo Street. See you there.
Over 10 million illegals have entered America during Kamala Harris's reign as the border czar.
Border czar.
Border czar?
Border czar.
And when questioned on the NBC Nightly News,
you haven't been to the border.
And I haven't been to Europe. And I don't.
criminal aliens murdering Americans, cartels trafficking poison, benefits for illegals. Kamala Harris is no laughing matter.
Right for America, paid for and is responsible for the content of this ad.
Hardworking family businesses, ambitious entrepreneurs, relationship builders, and job creators. Businesses like yours are the heart of Wisconsin, and Wisconsin Economic Development Corporation lives.
But you know, God is good because it was revealed, so you didn't get in there and then you done signed it. So we just praise God for revealing.
Mm-hmm.
So it's all good, you know. Like Dorothy said, sometimes God's delay is delivering.
Mm-hmm.
You know, doctor, she trying to help me out because then she threw this one on me and she knows it's gonna take me a minute to get through it. Even though it looks normal, I gotta look at the whole thing, and I'm looking at.
Caller, are you there?
Hey, hello?
Hello, caller. How are you doing, sir?
Hey, good morning, ladies. How you doing? Question is this. As it relates to cancer, I have a sister who just found out was diagnosed with cancer. And I know that sometimes it can be aggressive. But I also know that when it comes to breast cancer, men can think that that's not their issue or their deal. But how important is it for the man, the partner in a relationship to be caring and understanding, because the stress from a relationship can that be hard in the recovery and the management of going through that situation, if that makes sense?
Yeah, I would say it's definitely it's trying
I'm gonna hang
for
up.
thank you, Andre. Appreciate you.
Thank you for calling.
There's there it's we call those the men that stand behind our women when they're diagnosed. They are co-survivors. They are going through the stress of the diagnosis, not being able to do anything about it, feeling somewhat helpless in a sense. Being able to support your wife or your partner or your sister as they're going through that is so critical. And it's not a matter of fighting it with them, but it's more so just being beside them to hear, to listen and hear. And actually, thank you for teeing that up. We do have a program that's coming up on November 2nd, again at Thrive On, that is care for the caregivers, distressing the holidays. The holidays can be very, very difficult during this time period because as I know as Black women, we want to get in the kitchen, we want to cook, we want to take care of everybody, make sure everybody has something under the tree. And with a diagnosis such as breast cancer, you know, the whole family feels this. And so men, not only as Dr. Izzer had talked about earlier about the possibility of being diagnosed, so you have to know your body, but also just being that partner there, knowing that and Keisha, you can speak to this. It's not, we don't necessarily want you to solve it, but we want you to hear, listen, and just be there. And Keisha, if you can chime in on that too, it's so important.
Yes, the care partner, the co-survivor, whether it's, you know, your partner, for me, my spouse, it's so important to have them to walk alongside this journey with you. I always think of my husband, Norris, if you're listening, shout out to you. But I always think
Shout out
about
to you. Yes, yes. Shout out to your
how
husband.
he has carried this burden with me, like going to the doctor's appointments, and just sometimes I look at, you know, his face and how he's feeling, and just knowing that it is something that he carries, and he does try to solve it. I can remember when I was first diagnosed, oh gosh, he was on the internet, he was looking up all these things, drink this tea, eat this, you know, and just trying to offer up, like Deb just said, some solutions. But there were times where I just needed to be held, and we kind of have this I guess agreement. I just let him know when I need more. So you know, I need a hug. I'm kind of like the dog. As soon as he walks in, like there's days I need an extra hug. I need an extra kiss. I need to just, let's ride in the car. Just go on a long ride. I need ice cream. I want, you know, iced coffee, whatever it is. And so I just let him know, because it is so important. Even though you can have your partner there living with you, just to recognize that this weighs on them as well, because they want you to be healthy, and they want you to be able to do all the things that you want to do and the things that they're used to doing with you. And sometimes, you know, he'll get on my nerves because he's like, watch your step, watch here, watch there. And I'm like, okay, I got it. You know, I'm good. And then sometimes I'm with someone else, and then I'm so used to him, like, watch your step, you know, open this door. And I always joke that, I mean, he's a great care partner, a great spouse, husband, but he wasn't always one who would open the car door. He is a Southern gentleman, but he would just be like, okay, you in, you good. But once this diagnosis came, it was like, dude, he had to open my door every time, because with the metastatic breast cancer, not being able to use my right arm as well as I needed to, he had to help me get dressed. He had to open those car doors and do a lot of cooking and the chores. And so that's kind of our inner joke that, okay, you wasn't, you know, always ready to open the door, but now you have no choice because I need it. So recognizing that they need support too, they need time to understand the diagnosis and how it really affects. I've mentored women who have had, you know, boyfriends, partners, whomever, that didn't stick around, and that does make it harder. So
Devastating, yes.
Being able to find the support, it's that wraparound support, not just for the patient, but that care partner or co-survivor needs it too.
You know, and I think, you know, what you just mentioned there, Keisha, is that a lot of times people, they get scared and they run because they feel like they can't help you. And so because they know that they feel like they can't help you, then they just feel like they need to just leave. And a lot of times what you mentioned to your husband is so significant that
Mhm.
you just sometimes want somebody to be there to give you the hug, to love you. And that support means a lot.
It
And,
does.
and did your husband seek, Keisha? Did he seek like um, some assistance with how to really, support you? I mean, how did you guys handle that?
You know, he can be a private person. He's also, a man of faith. So I think inwardly, he went to himself, and then he had some friends, but no, like professional. Not that that's off the table for either of us. But I think he went to like some of his networks, in terms of like his close friends, for support. And some of them also, it's interesting as you get to this point, in your life when you've been with someone for so long, like you can start having your own health issues, or you see that your friends that you've had for years, like, okay, now their wives or husbands is having like a serious health issue, and those are conversations that then they could share and talk about how they're each supporting and just try to be there for one another. So I think he garnered his support from within his own circle.
Thank you so much, Keisha. And Karen, we have another
Yeah,
caller.
I was
Someone
going to
else.
ask that. Yes, we have
Yeah.
another caller on the line. Good morning, and thank you for sitting at the table.
Well, God bless you all, and thank you. Please forgive me for coming for a double scoop, but Tyrone W. speaking. Good morning. I love my ladies and the doctors. Thank you, Dr. Keisha, for sharing all that with us. Thank you, Dr. Deb Nevels, for the knowledge. Very, very informative this morning, and Ms. Dobson as well, Dr. Dobson. We was talking with Dr. Izzard earlier, and I'll just say for expecting young ladies that's pregnant, even before and even after the diagnosis, but let's start with before. Before she gets diagnosed with, or possibly, does that somehow or another taint or taint the milk, and then after, whatever, perhaps she has the baby, and then, she has to go for therapy, and then, after she's had the baby, what does that do to the milk then? And I'll listen to you over the air. Thank you. Have a great day and a wonderful weekend. Thank you. Love you all.
Just sitting at the table.
Thank you so much for the call. And here I am with Dr. Google. I know once you get, if you're doing chemotherapy or radiation, then breastfeeding is not an option. Of course, if you have the mastectomy, that also limits it. So people, it's really, really important that so many young women often find their diagnosis during that time, because your breasts start to get tender and you're trying to figure out what's going on, and all of a sudden you feel a lump. And so breastfeeding is usually not an option once you've had a diagnosis. And that's, Keisha, if you can.
And yeah, I would definitely say, just like referring, and with a lot of the mentoring and support groups that I'm involved in, always definitely referring the patient back to their medical care team to get that information and targeted approach to what's going to work best for them. And then to be able to provide some additional resources if she's unable to breastfeed, to know what the other options are that can be supportive to her in that.
The other thing too, there's been some research that actually breastfeeding reduces your risk. So, and I'm sure my friends at African American Breastfeeding Network, Dalry,
yes.
give me some credit here. But yeah, because they support breastfeeding and they help young ladies to learn how to do that. But it actually reduces your risk of breast cancer. So that breastfeeding is very, very critical and very important, not only for the baby but also for the mom.
You're right. That is so key, Deb. Keisha, there are so many different programs and things that you're involved with. I read about the ABCD. Can you talk to us and tell us some of the programs and the things that you are doing in this effort?
Yes. ABCD, I think after my diagnosis, I was just looking for a way to give back. So I became a mentor with a wonderful organization called ABCD After Breast Cancer Diagnosis. They offer free emotional support from trained breast cancer survivors to someone newly diagnosed or anywhere along their survivorship journey. We do that for women and men. that are diagnosed. And also we offer support to their caregivers or, partners if they also reach out to us for support. Our services are virtual. So for anyone that's looking for a patient that's either referred to us by a healthcare professional and or just a patient who reaches out to us on their own for support, what makes us so unique is that we will match them with someone who shares their very similar breast cancer diagnosis. So we'll match them with a mentor who has had the same type of surgery, same type of chemo. And then we'll go a step further and match them with someone who shares some of their same similarities, whether they're vegan, whether they're a person of faith, whether they're a mom, they're married, they're a grandma, they like to travel. So those types of relationships, I know for me, being able to talk to someone that went through the same type of surgery that I did and had, adult children like I did at the time was just helpful to know, how did you talk to your kids? How did your spouse support you? And just to have those similarities. So being able to be involved with that after my own diagnosis definitely helped me to learn how to give back and be ready to receive support and give support. It also helped me. I started a local chapter of Sisters Network, Sisters Network of Southeast Wisconsin. We help women in Kenosha, Racine, and Milwaukee counties by offering them opportunities to come to different outreach and awareness programs. We offer care packages when people contact us and let us know that they have a relative or a friend that's newly diagnosed. So we try to do we do health fairs, we do breast cancer awareness walks. We go into the churches. We have a lot of, churches that will do a health fair or some type of ministry program, a Pink Sunday, where they want us to come and give us the opportunity to share information about the work we do. Sisters Network itself has been around for 30 years. It was started by a phenomenal breast cancer survivor in Houston, Texas, Miss Karen Jackson, and she wanted it to evolve into the local community so survivors are able to start their own chapter. So we have an amazing group of women who, Deb, as she mentioned earlier, is in our group. It consists of survivors and supporters, and really just rallying around our sisters to give them that support once they are diagnosed.
So, Keisha, if someone wants to reach out to you to get involved, or they want to just know more about, some of the challenges that they're going through, how can they reach you?
So I'm going to give out two numbers. So for Sisters Network of Southeast Wisconsin, we do have our Facebook page. So Sisters Network Southeast Wisconsin could be searched on Facebook. If you wanted to go to the national website, it's just sistersnetworkinc.org. But our local phone number for support is 262-488-7465. And so then they could be connected with us, and we do would love to get them connected and offer that support and outreach. For women or men looking to have that one-to-one peer support, or they might need some additional resources like questions about transportation or medical wigs or financial assistance. While ABCD does not offer that, we do have vetted resources here locally and nationally that we can connect them to. So if anyone is looking to get support as someone newly diagnosed or in their survivorship journey, they could call ABCD at 1-800-977-4121, and then we can get them matched with a mentor. We have over 250 mentors. I would say about half are located here in Wisconsin, and the other half are located in other states, but they begin talking over the phone in order to offer that emotional peer support.
That is so important and key, because that really helps with the healing, to have that support that you're able to provide to the community. And for those that are just joining us, we're talking about breast cancer. And also, this is Breast Cancer Month. So there's going to be tons and tons of different activities that are going on. I know Deb Nevels had mentioned quite a few different things. She was going on and on about all those supporting things that were happening this month. And we want to make sure that you know, and we're going to mention that to you before we conclude today. But Keisha, on your journey, on your walk, what has been the most significant thing that you have experienced or worked through that you want to share with the community?
I would say relationships and just the advocacy for yourself. So with relationships, for people who sometimes I hear from friends of someone who's diagnosed and they're not sure how to support the person going through the breast cancer journey, because it is isolating. And sometimes people can feel left out if you weren't the first person to learn or they didn't tell you right away. But give your friend, your sister, your mom, whoever it is, give them that grace and that time that they need to just digest what's happening to their bodies and to understand. So sometimes we might pull away, or it might look like the breast cancer patient is pulling away, but really they're just trying to find understanding within themselves about what's happening with their body. And in time, they will share. For me, it's important to make sure that women and men know their family history and that you at least are sharing that. If you're not ready to go Facebook Live and share your, full breast cancer journey, that's okay. But make sure that you share it with the people that need to know so that when they go to the doctor, they can be sure to say, yes, this does run in my family, so that if they need to be tested or screened earlier, they can get that done. So being able to just meet people where they are. And so just to understand, to show that grace, just still show up. How can you support your friend that's going through, even if you're not talking to them like you're used to, because just know that they are changing, not just physically, but emotionally. And so they still need your support. And the advocacy part, making sure, as I stated earlier, that you know what type of breast cancer you have and that you advocate for yourself. I was able to get some additional testing to determine a cell mutation that I carry. And now I'm able to take the proper medication that keeps my cancer stable and keeps it from growing at this time. But without that additional testing, then I would just probably still be taking a regular drug and could have progression. So it's important to advocate for yourselves. Some days, I feel like I'm on a emotional roller coaster, or kind of the teeter totter, the old school playground ride where, one day I'm on the emotional side, the other day I have to put on my educational side and advocate and make sure I ask questions to my doctor, that I'm doing my own research, especially I know we talked a little about clinical trials and just being aware of what's out there, not being afraid to ask those questions and really get the support. There's so many resources. Deb has mentioned so many, and so many just mentioned this morning. So just knowing that there's resources, there's support out there, and that we need to know about it and ask those questions, and we can get the help that we need.
And Karen, if I can follow up with regards to the resources, there, count on our community. Someone just text me with some information. There's an event going on October 17th through Health Watch Wisconsin and ABC for Health. This is happening at the Zufari Center, begins at 8:30, and this is talking about medical debt. And that's one thing. A cancer diagnosis can be extremely expensive. It can be, and long-term treatment can be extremely expensive. And so this is a session. Thank you, Queen Herrera, for sending it to me. This is an opportunity to kind of talk about medical debt. The other piece to bring up, something that people are going to start seeing, some legislation. As you know, my other hat, or part of my role is also policy and systemic change. And so there's been some legislation put in place where women now, when you get your mammograms, you're going to get additional information in the letter that you receive that talks about whether or not you have dense breast. And that dense breast is yet another opportunity for you to have a conversation with your doctor to find out more about, okay, what is going on, what is happening, and how can I be proactive? Is there a reason why I have dense breasts?
Yeah, but explain dense breast. What is that?
I want to thank Carla Harris for helping me understand this a little bit better. So dense breasts, it means that you just have tissue that's a little bit. It doesn't mean that it doesn't mean that your breasts are big. That's not it. There's just tissue that's overlaying. And one of the reasons I know so well, I have dense breast tissue, and so on my mammogram, there's some sections that show up, look like ghost white is how I like to describe it. And it just is an area where the tissue is just a little bit denser. It's a little bit thicker. And it's something that if you have it, if you have a diagnosis, if you have a family history, instead of the mammogram, the doctor, and this again, working with your doctor to find out, the doctor can say, instead of a mammogram, I believe it's medically necessary for us to do an MRI or a different type of test. And so it's something that you definitely need to follow up on and watch. For me, I get mammograms more often than most women my age. And so because I have that dense breast tissue, I also have sickle cell trait. So there's things, and there's also a history of cancer in my family. So this is something that through the research, they have found that this is important to pay more attention to.
You know, we're only going to have a few minutes left, but I wanted to give Keisha an opportunity to at least say to the community, Keisha, what do you want the community to know before you leave us today?
I definitely want the community to know, and the statistics might have been stated earlier. I think we hear so much the 1 in 8 women will be diagnosed with breast cancer at some point in their lifetime. But for African American women, just for us to know that we are 42% more likely to be diagnosed than any other demographics, and twice as likely to die from breast cancer. So it's important for us to prioritize our health. I know we take care of so many family responsibilities, but let's prioritize our health, put ourselves and our health first, and make sure that we continue to get those mammograms, but to be aware of our bodies and to speak up and ask those questions of our healthcare team so that we can get the support and services that we need.
I want to thank Keisha Jones and Deb Nevels for talking today about breast cancer. Before we conclude, I just want people to know that the All of Us Research Program, we are the largest database in the world right now. And if you are interested in joining to help researchers identify how to better help our health and precision medicine, and also for you to get back, information about your genetics too, free. So I would like for you, if you are interested in our program, you can call us at 414-955-2689 or go to joinallofus.org. There are a couple things going on this month. We have some events at Independence First. We'll be there October 7th. We'll be at Curative. We're having a pop-up, you guys, and we need people to call and get on. We're having a pop-up at Curative on Saturday. And that's going to be on October 12th. So please call us because we have openings for you to join our program at 414-955-2689. We'll be at Outreach on October 11th, Outreach Community Health Center, and then also at McKinley on October 9th. So we're in the community. We're doing things. We want you to be involved. We thank Deb Nevels and Keisha Jones for joining us today. At the table, we'll look forward to in the next 2 weeks seeing you at the table with some hot topics. Everybody have a wonderful, wonderful weekend. Thanks everybody for joining us at the table this morning.